I just want to first start by welcoming everybody to our MedRhythms Videocast series. And this is, if you've been following along, a monthly series where we'll be talking to world experts in the field of neurology and research, rehabilitation, and music, and discussing all things from digital therapeutics to rehabilitation and music and neuroscience. Each month, we feature a new expert who will provide valuable insight into these important topics. This show will be hosted by me, Brian Harris, the co-founder and CEO of MedRhythms, a digital therapeutics company focusing at the intersection of neuroscience, technology, and music to build interventions that transform the lives of those living with neurologic injury and disease. If you'd like to learn more about MedRhythms, please visit our website at www.medrhythms.com. And I hope that you'll find today's episode interesting and meaningful and compelling, and I believe that you will. Today, I'd like to introduce our esteemed guest, Dr. Alexander Pantelyat. Dr. Pantelyat is an assistant, I'm trying to get over here. My apologies. Dr. Pantelyat is an assistant professor of neurology at the Johns Hopkins University School of Medicine. He's the director of the Johns Hopkins Atypical Parkinsonism Center, the co-director of the Johns Hopkins Movement Disorders Fellowship Program, and the co-founder and co-director of the Johns Hopkins Center for Music and Medicine. His research explores music-based rehabilitation of neurodegenerative diseases, diagnosis and treatment of atypical Parkinsonian disorders, such as dementia with Lewy bodies, progressive supranuclear palsy, corticobasal syndrome and degeneration, and multiple system atrophy, and cognitive aspects of movement disorders. He earned his medical degree from Temple University School of Medicine in Philadelphia, where he was elected a member of the Alpha Omega Alpha Honor Medical Society and received the Matthew T. Moore Prize in Neurology. He completed his residency training in neurology at the University of Pennsylvania in Philadelphia and a fellowship in movement disorders at the University of Pennsylvania, Philadelphia VA Medical Center. In addition to all the above, we are honored to also have Dr. Pantelyat as a member of our MedRhythms Scientific Advisory Board in Parkinson's disease. So welcome, Alex. It's an honor to have you with us today.
Brian, thanks so much for having me. It's a pleasure to be here.
And just to get started with the conversation, we'd love to have you tell us more about your work as the director of the Atypical Parkinsonism Center and the Center for Music and Medicine at Johns Hopkins.
Sure, I'll try to be brief for the sake of our audience. So I was brought on to Johns Hopkins to establish a program in atypical Parkinsonian disorders, which are cousins, relatives of Parkinson's disease that collectively share the many of the core symptoms of Parkinson's disease, but tend to respond less well or not at all to the established treatments that we have available for Parkinson's disease, and also progress much more rapidly from symptom onset to severe disability and death. So just to put things in perspective, to give a little statistic, large studies have shown that Parkinson's disease, if it does shorten lifespan, it does so by an average of maybe about a year compared to age and gender matched people without PD. This is very different from people with atypical Parkinsonian disorders. They most certainly do shorten lifespan. And increasingly, we think of these diseases as prime of life diseases, people who plan their retirement, let's say in their 60s or early 70s, and want to enjoy 10, 20 plus years of retirement. These are exactly the years that are taken away by these awful diseases. So I was charged when I came to Johns Hopkins in 2014 with establishing a clinical and research program dedicated to these neurodegenerative, age-related Parkinsonian disorders. And what we did was establish a multidisciplinary clinic that also has a research connection. So patients on a monthly basis come through the clinic and they see one of several clinician experts. They see educator. Often there's a social worker, either on site or just available for contact. And they see physical, occupational, and speech and swallow therapy all in a single visit. So this we found to be an effective multidisciplinary approach for the management and really a tune-up of patients for these diseases. In addition, we have several NIH-funded grants and other research grants dedicated to biomarker discovery and validation in these disorders. So one grant focuses, for example, on magnetic resonance imaging, finding imaging signatures for some of these atypical Parkinsonian disorders. and another grant focuses on cerebrospinal fluid, so spinal taps to get fluid and analyze it for protein content that could distinguish patients with some of these disorders from healthy older individuals and from Parkinson's disease, which can be very difficult to do, especially early on in the disease course. So to switch gears, my passion in life has been music. It's what I would be doing professionally if I weren't in medicine. And again, I always say this for the sake of my patients, I hope I'm a much, much better physician at this point than I am a musician. But nevertheless, I started playing violin when I was 8 and have been doing it ever since. It's a huge part of my life, and it's my respite. It's my way to relieve stress and so much more than that. So I feel very fortunate to be given the opportunity at Hopkins since 2015 to co-found and now lead the Center for Music and Medicine that we have. And so our motto can be summed up by saying it's music as medicine and medicine for musicians. So it's a dual vision wherein we aim to bring music and medicine together by integrating music-based and rhythm-based interventions into the everyday care of our patients, not just with neurological disorders, but really thinking outside of that. And also, just as important, we need to learn more about how to diagnose and treat and hopefully heal musicians themselves, professional serious musicians who can have a number of serious occupational illnesses and injuries that could befall them. So really the goal there is to create a new subspecialty of medicine, a sports medicine of musicians, if you will.
I love that analogy, the sports medicine of musicians, and such an important need too. And, you know, as you think about the mission for the Center for Music and Medicine, you talk about the importance of music and rhythm to be used in the treatment of neurological illness. Why is that important?
Well, we now know on the basis of studies conducted over really the last several decades that music can impact the brain in very profound ways. In fact, while it's difficult to directly quantify this, it's thought that music activates, just listening to music, that is, activates arguably more brain areas simultaneously than any other human activity. So for example, when one is listening to a piece of music, you have to pay attention. So the dorsolateral prefrontal cortex, the frontal lobes is involved. If one is making any sort of movement to music, of course, you have the motor parts of the cortex and the brain that are activated. And that's very relevant to what we're going to discuss in a little bit about Parkinson's disease, the connections from the deep centers in the brain, the so-called basal ganglia, to the frontal lobes, the frontostriatal circuits that are disrupted in Parkinson's disease and can potentially be either restored or augmented through music and rhythm. At the same time, we know, I hope all the listeners know from personal experience, that music can activate the emotional parts of the brain in very powerful ways. I don't want to show my bias too obviously here by saying, oh, this is going to, music can bring about pleasurable emotions in everybody, because fact of the matter is, depending on the context and the piece of music, you can activate the amygdala and the fight or flight response will be in play. And so you might want to run away or shut your ears and not listen to a given piece of music. Be it as it may, pleasurable music can produce activation in the same areas of the brain that cocaine, alcohol, and other drugs of abuse are able to produce. And the degree of activation is similar. So can music be addictive? Perhaps that's a topic for a different webinar, but it's certainly something that subserves a network for motivation, which can explain why people keep coming back to listening to music, particularly music they enjoy, time and time and time again. And this motivational aspect of music listening, and also, as we'll talk about, rhythmic entrainment, are very important when it comes to music and rhythm-based rehabilitation, helping people heal through music and rhythm.
Yeah, and it's a really interesting point that you make, and I love that you point out that it's really sort of activates our brain sort of more globally as we think about than really any other stimulus or activity. which then lends the question of, well, how can we use that to benefit patients, right? And you talk a lot about the emotional characteristics that we all can, I think, relate to. And as we're going to dive in today, we're going to talk specifically about Parkinsonism and atypical Parkinsonism as well, and then very specifically about movement. And we could have a, hours upon hours conversation about each one of these topics because it's such a profound and powerful stimulus. And I think that that's a good sort of foundation to set up the rest of the conversation. And as we think about sort of Parkinsonism and atypical Parkinsonism, could you, give for the listeners here an overview of sort of what we would expect to see for symptoms of the disease, how do those diseases manifest, and what are some of the more specific differences between the two?
Happy to, of course, Brian. So the way we teach the medical students is often through mnemonics, and this is helpful in this case. So when we think of the core motor movement-related symptoms of Parkinsonism, so Parkinsonism is not a diagnosis, to be clear. It's a syndromic clinical description of one of the following four symptoms or their combination. T stands for tremor, shaking of the hands or other body parts. R stands for rigidity or muscle stiffness, typically the large muscle groups of the arms or legs, could be the neck, could be the back. A stands for akinesia, which is a bit of an outdated term. It really refers to the loss of fine motor control and coordination and the progressive slowing of rapid alternating movements. So if you could see me tapping my fingers, imagine tapping your toe to the beat of music that you like. That tends to become more difficult. That's bradykinesia in doctor speak. And finally, P stands for postural instability. That's walking and balance difficulty that ultimately can lead to falls. So the mnemonic is trapped by Parkinsonism. T for tremor, R for rigidity, A for akinesia or bradykinesia, and P for postural instability and gait or walking difficulty. Among those motor symptoms, the last one, P, or for postural instability, tends to generally be less responsive to any treatments that we currently have available, be it replacement of dopamine in the brain, be it deep brain stimulation surgery. And really, it's a huge unmet need, motorically speaking, for Parkinsonian disorders. So the most common cause of this constellation of symptoms, TRAP, mnemonic, is Parkinson's disease. Let's make no mistake about it. However, there's a differential diagnosis that it's my job as a movement disorder specialist focusing on Parkinsonian disorders to figure out. And so collectively, these atypical Parkinsonian disorders, formerly known in the literature as Parkinson plus disorders, they're also degenerative. They also are associated with progressing with older age. So that's something to keep in mind, like Parkinson's disease. But they have additional symptoms that people with Parkinson's disease either never develop at all or develop much later in the course of the disease. So early onset, for example, of postural instability and falls is a hallmark for several of the atypical Parkinsonian disorders, particularly progressive supranuclear palsy or PSP and multiple system atrophy or MSA. Of course, I'm happy to delve into more detail, but just to give a few more examples, dementia with Lewy bodies is on a spectrum with Parkinson's disease. In the sense that what we know about it when we look at the brain at autopsy through the microscope is that dementia with Lewy bodies is involved with clumps of a protein called alpha-synuclein called Lewy bodies, and these are the same type of clump that we see in Parkinson's disease. However, for reasons we don't fully understand, those clumps, the Lewy bodies, are much more widespread in the brains of people with dementia with Lewy bodies, and they affect some of the areas of the brain that are either less or not affected in Parkinson's disease. So people with dementia with Lewy bodies develop cognitive difficulties much earlier than people with Parkinson's disease do, and that is an important hallmark. In addition, they develop visual hallucinations that are not provoked by medication. They can develop significant ups and downs, fluctuations in their alertness and attention, ability to respond to any stimuli over the course of a single day, even, or from day to day. And so these are some of the distinguishing features, for instance, for dementia Lewy bodies. Apart from dementia from Lewy bodies, the other three neurodegenerative atypical Parkinsonian disorders, so that's PSP, MSA, and corticobasal syndrome, they are significantly less common. So what that means is that unfortunately, there is a dearth of people who are able to identify these diseases. So what that means is that often patients and families have to go through multiple specialists until they finally get to someone who has seen this type of disease before and is able to confirm the diagnosis. That also means that appropriate care, referrals for rehabilitation can be greatly delayed, and that hugely impacts the quality of life for patients and caregivers. So one of the things that I'm dedicating my professional life to is to get the word out on these disorders, which is why I appreciate the ability to talk about it in this webinar.
Yeah, it's important, from access to diagnosis to access to care. I mean, across medicine, this is an important topic. So I appreciate you bringing that up. And as we think about sort of going deeper down, start broad and come deeper down. At MedRhythms, we're focusing a lot on gait. We focus a lot on rhythmic auditory stimulation, which I know that you know well, and it's an intervention that leverages neuroscience principles of the connection between the auditory and motor system to improve walking. And we know that RAS, rhythmic auditory stimulation, has been studied for nearly 3 decades across neurological illness. However, there's actually the most evidence that it works in Parkinson's disease. Can you talk a little bit about that evidence that supports the use of RAS and PD?
I'm happy to, yes. In fact, to my knowledge, I think the first paper describing RAS dates back to the 1970s, but as you said, when applied to PD, it's around 3 decades. So there's a growing body of literature that suggests that having an external sound cue to help guide movement can be helpful. And so the concept behind this is this idea of rhythmic entrainment, which really is nothing more than the patterning of body processes, whether external or internal, to a stimulus. So in this case, we're talking about, let's say, hearing a drum beat. Imagine you hearing a strong beat, whether it's a drum or a piece of music that's got a strong beat that you just enjoy. And next thing you know, you find yourself tapping your foot. You are rhythmically entraining, okay? And this is something that people experience, pretty broadly. Another good example, I think, is perhaps not the best example during a pandemic, but this will, again, this will be something we'll all be able to experience. Imagine yourself at a rock concert, and the band is asking, the people in the audience to clap along, whether it's 100 people or 1,000 people or 10,000 people. It's remarkable how quickly people get in sync with each other. If you ever think about why that happens, it's because their brains are in sync. So there's actually evidence from healthy individuals showing that people can rather quickly, often within seconds to a few minutes, entrain their brain waves, their electrical activity in the brain, to an external rhythm, to an external sound, whether they're clapping along or tapping along, or even if they're just listening, even without any external activity. It's remarkable that our brains are able to rhythmically entrain and engender a pattern of expectation. In other words, oh, okay, I've heard 5 beats. I know the 6th beat is going to be in 200 milliseconds or 300 milliseconds. And the cool thing about it is it's unconscious. It's not something that we have to think about. So that connects to what happens in Parkinson's disease in the following way. Mark Hallett and others at the NIH and other centers have shown very clearly more than 15 years ago that people with Parkinson's disease lose our normal ability to perform automatic movements, automatic in the sense that we don't have to think about them. And so walking is a great example of that, right? We don't normally have to think about taking a step with the left foot and then paying attention to the right foot, unless, of course, you're on uneven terrain or, you're trying to do a tightrope. If you're walking on regular, even ground, we normally don't have to think about it. We could even do things like chew gum and walk at the same time. Well, unfortunately, patients with Parkinson's disease, due to the loss of dopaminergic innervation to the key areas of the brain, I mentioned the basal ganglia, deep centers in the brain, and the connections to the frontal lobes, they lose the ability to do this automatically. What that means is they have to pay extra attention by using the frontal lobes to ensure that they're able to walk in a more normal pattern. And we know about this from several lines of evidence, but one compelling line of evidence clinically that we know about is if a patient seems to walk more or less normally, and we know the patient has Parkinson's disease, you ask them to do a simple additional task, like saying the days of the week backwards, Sunday, Saturday, Friday, Thursday, or the months of the year backwards, December, November, October. It's remarkable that even in early disease stages in Parkinson's disease, their gait breaks down. It really starts looking a lot more impaired. And so this is indirect proof, and we have additional proof from other studies, neurophysiological studies, that patients with Parkinson's disease need to basically use additional areas of the brain to compensate for the loss of certain areas of the brain and the dopamine receptors that normally enable us to walk automatically without thinking twice about it. So what does rhythm do to try to improve this problem? We don't currently know for sure, but the two proposed lines of thinking, theories, are that the external rhythmic cue, by helping people entrain their brain, as I mentioned before, it could in some ways get around the faulty pathways that are affected by the progressive nature of Parkinson's disease. Parkinson's disease and other atypical Parkinsonian disorders we've been talking about, they involve the progressive loss of brain cells in specific networks, just to be clear, because I don't think we mentioned it before. And so it's possible that by giving people an external cue, you could get them to walk with more automaticity, which is what we want. That's more normalized than otherwise. And that could be by recruiting the cerebellum, for example. That's been hypothesized. That's an area in the back of the head which tends to be either not affected or a lot less profoundly affected by the loss of brain cells in Parkinson's disease, or possibly by strengthening some of these impaired, partially disrupted pathways between the basal ganglia, the deep centers of the brain, and the frontal lobes. So the jury is still out in terms of which mechanism predominates, and there's a lot more research that we would like to do on this in our center and others, but those are currently the leading thoughts, that by giving people an external rhythmic sound stimulus, you could help them become more automatic because they entrain their brain and they anticipate the next step without necessarily having to pay as much attention to the step itself.
Yeah, and that's a really good point. And actually, I'm glad that you mentioned that at the beginning when we talk about historical research that supports this. You mentioned the early 1970s, and I think that was some of the seminal work by Melville and Rosignol that showed that you could actually use an external stimuli to engage the motor system, to prime and time those networks. And then it was more in the early 1990s that was actually sort of used as an intervention. So one, that you could show that you could actually entrain the motor system or engage the motor system with rhythm. And then in the early 1990s by our friend and colleague, Michael Tout, who was actually just on our videocast last month, who was some of the early research to show that you could actually apply this to people with neurologic illness, which then showed unique functional outcomes. And so according to that research in Parkinson's disease and sort of how the intervention works, what type of outcomes does rhythmic auditory stimulation address, and what improvements are we seeing in sort of those more clinical measures?
Yes. So I will start by saying that the Holy Grail, our ultimate goal as doctors and specialists trying to treat Parkinson's disease, is to help prevent injury from falls. This is a very significant problem. And let me just step aside and say that it is an even more frequent, severe, and significant problem in people with atypical Parkinsonian disorders across the board. All atypical Parkinsonian disorders, falls are an even more severe and significant issues, and frankly are a fairly common cause of death for people from severe injuries. So in Parkinson's disease, especially as it progresses, falls become a growing concern. And so if we can normalize several aspects of walking through rhythmic auditory stimulation, it's possible that we'd be able to prevent falls. And I'll start at the end again by saying that Michael Tout's group elegantly demonstrated that falls can indeed be prevented in a study that they published in 2019, where patients with Parkinson's disease walked for 30 minutes at home, 5 days a week, along with basically a metronome guided beat, an external sound, according to a rhythmic auditory stimulation paradigm. And at the end of, this was a short study, admittedly, I think it was a month. At the end of the study, they demonstrated a clear reduction in falls. Now, that study needs to be followed up and done in a multi-center way, ideally compared to another intervention to explore this in more detail and try to get a bit more of the mechanism, hopefully. But it certainly is an important proof of concept that this rhythmic auditory stimulation may help reduce falls in Parkinson's disease and perhaps other Parkinsonian disorders. Now, how does it do it? Well, from what we understand, it tends to normalize some of the same parameters that we try to normalize by referring patients with Parkinson's disease to programs of physical therapy rehabilitation, such as the Lee Silverman Voice Treatment BIG program, LSVT BIG, representing big steps. Steps in Parkinson's disease progressively become shorter, ultimately leading to a phenomenon called shuffling, an even more significant phenomenon called festination, whereby steps progressively get shorter as one even walks a short distance, and eventually lead into a complete freeze. So the feet get stuck to the floor, and that greatly increases one's chances of falling forward if they're impelled by their momentum from having walked before. So that's one aspect of things. The variability of steps, again, remember, we talked about how gait becomes less automatic in Parkinson's disease and related disorders. There's a significant variability between the timing of each step, of the footfalls, of the distance that each leg travels before it lifts off again, before it steps. Those variables have been shown in various studies to become more like normal, more normalized in people with Parkinson's disease. So speed of walking, which slows down progressively with Parkinson's disease, has also been shown to improve with rhythmic auditory stimulation. That's probably the most consistent finding across multiple studies, because what you're essentially trying to do, one of the things you're trying to do with rhythmic auditory stimulation is drive the speed of walking. So if somebody is walking, let's say at 100, let's say at 90 steps per minute, and you're driving them to try to walk faster with rhythmic auditory stimulation at 100 beats per minute, and they're able to step once to each beat, which is generally what we try to get them to do, then over time, it's been demonstrated in studies and in our clinical practice with Brian that people can actually learn this, and it could even be carried over whereby people continue to walk faster even without the rhythmic sound cues. And that, of course, is the other key point that we want to see how much carryover there is from this kind of therapy. So gait velocity, stride length, the distance between footfalls, which becomes shorter in Parkinson's disease, and we're trying to often lengthen it as part of our rehabilitation technique, and ultimately the holy grail, which is fall prevention. Those are some of the key aspects of walking we're trying to get improved.
Yeah, and I sort of like how you worked backwards there, because really when we think about fall prevention, as you said, the holy grail, all interventions, us as clinicians and sort of what we're trying to build to help people is really about giving people their lives back, giving people independence, giving people autonomy to live in home, to live in the community. And as we think about, closing this loop about rhythmic auditory stimulation, which is, it's a neural input, it's a neural intervention that drives auditory motor entrainment, which then, because of the auditory motor entrainment, improves biomechanics, things like speed, variability, stride length, which you said. And then by virtue of improving speed, variability, et cetera, those are the two things that have been shown that are most tied to fall risk. And therefore, by improving those mechanisms or improving those mechanics, we can then have an impact on independence, on fall risk, et cetera. And that's really what this is all about, right? Is it really about getting to that? How do we improve the lives of those patients that we're serving?
Thank you, Brian, for spelling that out. And I just want to add one very important point that occurred to me as you were talking about this. Important aspect, just on a human side of patient care, an important aspect of what gets lost in people with Parkinson's disease, especially those who have experienced the fall or have had near falls before, is confidence, loss of confidence. What we're trying to do here is build people's confidence. If they feel like they are less likely to fall, then there's a lot that they could perhaps engage in that they otherwise would self-limit, from engaging. And so this is a very, very important point, because the other related aspect of this is that we know that regular aerobic exercise, physical exercise with an aerobic component, may actually slow down progression of disease, progression of brain cell loss in Parkinson's disease. There are multiple studies indicating this. We don't yet have a pill that can do that, but we have aerobic exercise that we need to make sure all of our patients engage in. And if they are prone to falls, if they've already fallen, if they have lost their confidence in walking, then giving them that confidence back, whether it's through rhythmic auditory stimulation or one of the other interventions involving music and rhythm or other rehabilitation, that would be a crucial step forward in helping our patients improve their quality of life.
Yeah, absolutely, and that's a beautiful point. So thank you for pointing that out. And I believe in the study actually with Michael Tout, the one that you referenced there, they actually looked at looked at fear of falling on an index as an actual outcome measure, where they actually showed that as people, which seems logical but important to point out, that as people were falling less, their fear of falling also decreased. And there's this sort of circular sort of component to that. But I think also in that study, the design of that actually was a randomized withdrawal study. So they actually gave folks the intervention, removed the intervention, and then gave the intervention back. And not only did they show that while they had the intervention, that they could make these improvements, they actually essentially showed that the treatment effects could be restored again when re-administered the intervention, which gives some hope for sort of the longevity of the disease, that as it progresses, that there's some potential for treatment effects to be restored and continued over time. So appreciate you pointing that out. And as we think about atypical Parkinsonism, right? So there's no research that I'm aware of that has ever been done that has looked at rhythmic auditory stimulation in atypical Parkinsonism. And if there has been, it's very, very small. Would we expect, from a sort of scientific or clinical perspective, would we expect there to be benefits to rhythmic auditory stimulation in that population? If so, or if not, why?
Brian, I'm really glad you asked, because while you're correct that there is a dearth of literature, we actually conducted a study that is currently in revision, and we hope to have an approved manuscript before long that we'll be glad to share with you. But in our multidisciplinary clinic at Johns Hopkins, we were able to offer rhythmic auditory stimulation right on site as part of that multidisciplinary clinic I described to you. So we trained our physical therapists on a basic rhythmic auditory stimulation paradigm. They had an app on their phone that was a metronome application. They assessed our patients, and we had all 4 diagnoses: dementia with Lewy bodies, multiple system atrophy, PSP, and corticobasal syndrome, whom we looked at. A total of over 50 patients so far, and this is an ongoing study. But they assessed their baseline cadence and gait velocity, so those parameters of walking that we talked about before. And then we were, humbly trying to do a proof of concept for this initial step to see if we could increase their slowed gait velocity by 10%. So what we did was we, in the context of our clinic, we gave them rhythmic auditory cues that were 10% faster than their own baseline. So that's an important point that I just want to emphasize, because this kind of rhythmic auditory stimulation is an individualized approach. One size is not going to fit all, whether we're talking about rhythmic auditory stimulation or other music-based interventions. Why? Well, frankly, because if you have 2 people, they probably won't like exactly the same type of music. And we know from a large body of research that it's personally preferred music that's most likely to make an impact. But back to our study, we were able to demonstrate in certain atypical Parkinsonian disorders, particularly progressive supranuclear palsy, that in the short term, they were able to improve their cadence and gait velocity and with rhythmic auditory stimulation, and that for a portion of those patients, that improvement was sustained in the short term, 10 to 15 minutes after the rhythmic auditory stimulation was over. So we had them repeat the same duration, a 2-minute walk, and their 2-minute walk times improved and remained improved even without the rhythmic auditory cueing with that short carryover. So obviously the next step is to make this a longer term assessment. And I'm very interested, especially given the pandemic, but even without the pandemic, to make it more feasible and accessible to patients and families to do this at home so that they're able to get trained and do this on a daily basis along the lines of what Michael Taut's study demonstrated in Parkinson's disease. So we have some encouraging preliminary results. I would say that people with dementia with Lewy bodies, they actually worsened, just to give you an example, in terms of one size does not fit all. And we think that that was the case because they had significantly lower cognitive ability. So we think that they were not able to follow through on the instructions from our physical therapists. And so in some ways, they actually had a worsening. But those folks who had only mild cognitive impairment, so the other atypical Parkinsonism diagnostic groups, actually had some benefit.
Yeah, that's really exciting research, and I wasn't familiar with that, so I'm happy to hear that you're going in that area and very compelling, and something to build upon. And you made sort of 2 points that I'd like to dive into, a little bit more. One being talking about sort of the actual application of rhythmic auditory stimulation. So you made the point about one being that music preference is important, both for engagement and for outcomes, that music preference is an important part of the intervention. But also, in addition to that, is that it's also about the clinical application of the rhythm. So it's about the right tempo at the right time for the right duration, et cetera. Because we would not expect, if somebody were to just put on random music and try to walk around, that we would see some level of improvement. It really is about getting the right tempo at the right time. And actually, in fact, we could hypothesize, particularly if we are talking about folks that have Parkinson's disease and are taking shorter steps, that actually trying to walk at the wrong tempo could actually, in fact, be dangerous for some folks. And I think that that's an important distinction as we talk about the intervention, that we don't want people just walking around their homes listening to random rock music and saying, oh, I'm listening to music, I'm going to get better. But it's really about the understanding of how the rhythm is impacting the outcome and how we purposefully use that.
Brian, I couldn't agree more. In fact, we were very careful in our clinical study I just mentioned, atypical Parkinsonism, to screen for aspects of walking that I mentioned before, like festination. Those folks with festination, you may not want, in fact, I could be more strong, you don't want to increase their gait velocity, to increase their gait speed, because it may make them more likely to fall. Similarly, people with gait freezing, so far it seems like slower stimulation may be more effective in helping them overcome their freeze, which is the feet getting stuck to the ground, a common issue in advanced Parkinson's disease and certainly in these atypical Parkinsonian disorders. So again, it's to emphasize the point that one size does not fit all with these interventions. We need to develop a form of precision music medicine, if you will.
Yeah, and that's sort of as we dive into sort of the next point that I wanted to make, which when we think about, you talked a bit about how do we bring this to people in their home? How do we enable people to do this in their home? But also, how do we enable them to do this in a therapeutically valuable and safe way as well? At MedRhythms, as you know well, that's why we started our company, was to figure out how do we bring rhythmic auditory stimulation to people's homes. What do you think is the sort of the promise of, or the potential, I won't put words in your mouth, what do you think is the potential of technology and digital therapeutics and this type of new innovative technology to be able to deliver these types of interventions in home? And why is that important?
I think the potential is great, and this was the case before the pandemic. But we all can agree that everybody in the clinical world can agree that the pandemic has put this much more squarely into our focus, because when there are restrictions, whether they are imposed from outside by a global once in a lifetime pandemic, or whether they're imposed by the fact that a patient has to travel 200 miles to see their doctor, which is the case for about half of my patients, unfortunately, for the multidisciplinary clinic, or simply the patient is simply too impaired, is unable to get around without substantial help. It's difficult for them to get into a vehicle and get to appointments or to research studies. For all of those reasons, even apart from the pandemic, we have had a focus for some time on developing tools, particularly digital tools, to both assess patients and hopefully treat patients in their home environment. So the pandemic, like I said, has brought this into stark focus, which is why I'm very excited about our collaboration with MedRhythms. And I think there's a tremendous need to have these kinds of therapies accessible in the patient's homes. And the other point to emphasize is that, frankly, I mean, people spend most of their time in their home, right? And so they do a tremendous amount of their movement in home. So if we're talking about rhythmic stimulation in particular, it makes sense to have it be accessible to patients in their home environment, because that's also where they're very likely to have falls or near falls or trip on furniture. So if these are things that we can ameliorate by digital technologies in the home, this is where we really should be going.
Yeah, wonderful point there, and thank you for that, Alex. And I think, as we come up towards the end of our conversation here, what do you see as the future of music research, whether it's rhythmic auditory stimulation or other music interventions for Parkinson's disease and atypical Parkinsonism? What's the future of research look like?
Well, as the director of the Center for Music and Medicine, I'm biased when I say this, but I do think that the future is quite bright. There are a number of projects that we have in collaboration with others, and also just at our center, that I'm very excited about. I have shifted my focus to an extent toward the inpatient hospital side. So at Johns Hopkins Hospital, there are several nursing-led projects that involve personally preferred music through playlists, whether it's Spotify, Pandora, for example, where patients have the ability to select a playlist. And we're looking at outcomes that we always care about, which is pain, medication use, particularly opioid medication use. We have another pandemic that's been sort of shoved aside that was ongoing long before the current coronavirus pandemic. We're looking at anxiety. We're looking at vital signs on the hospital side. So we have a pilot rolling out in 5 units of the hospital, 1 pediatric and 4 adult, which we hope ultimately to expand to all units of the hospital. Also, we are currently analyzing data from a project, again, that was led by a nurse from urology, where men undergoing radical prostatectomies had the opportunity, actually were randomized, but could enroll in the study, where they were randomized to a relaxation track that was the standard of care offered to all patients, or to a personally preferred music playlist. And again, they were looking at both preoperative and postoperative anxiety, pain control, level of medication use, and vital signs. So we hope to be submitting those data for publication before long. But I think the future is bright. And again, I want to emphasize by giving these couple of examples that it's not just Parkinson's disease. It's not even just neurological disorders. There is a growing body of literature that music and rhythm can be beneficial across other disease entities and across many aspects of health. And obviously, as a movement disorders neurologist, I know that there's no way I could follow all of this research, and I need to collaborate with people who know a lot more about this in their own field than I do.
Yeah, it's remarkable. When we put that into perspective, we're in one conversation talking about music as an intervention for walking and for pain and for reducing medications. It's quite remarkable about the stimulus of music and its profound impact on the human condition, and specifically on the human brain. So Alex, thank you so much for your time. It was such a fantastic talk here today. And I think to sort of put a nice bow on today's conversation, and I asked you this in advance, but there was a part in time in your life where you thought perhaps you might become a professional violinist. And that's something that sort of continued as a passion of yours to today. So I was hoping perhaps you could give us a song to go, if you will, to close out the session today.
It will be my pleasure. Brian, thanks again so much for having me. And I do apologize in case this is picked up on the audio. My 11-month-old is very excited about what I'm about to do.
As they should be.
Thank you. In terms of the choice of piece, I thought that Antonín Dvořák's Humoresque would be especially appropriate to provide a little bit of levity for us in this very difficult moment for the world in general with the pandemic and for our country specifically. So this is going to be Antonín Dvořák's Humoresque. Thank you.
Absolutely beautiful. Absolutely beautiful. Thank you so much, Alex. What a gift that was. And I really appreciate your time, your experience, and your music. So thank you for being with us. It's been an absolute pleasure.
Likewise, Brian. Thanks again for having me. Hope
Great.
everyone stays safe and healthy.